Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. Today, we're going to talk about some of the things that have been in the news and just that you need to get updated on, and making sure that you have them as we head into next week and into 2021 further. One of the things that has come up is the vaccine codes, and there are different CPT codes based on the provider, or I should say the manufacturer or brand name that is sending out the vaccine. And so it's important for those of you that are doing anything to bill these services that you have to be both specific to the manufacturer, but also dose specific. And so there's been some codes created by the manufacturer that have been put into CPT for 2021. And let me just give you kind of a snapshot. Also, search out the American Medical Association. They have kind of a shortcut to show you what you need. And here's an example. So vaccine code 91301, that says vaccine administration codes track which dose in the regimen is being administered, and then it gives you first dose. It tells you manufacturer is Moderna, and then it tells you what the name is, and the vaccine name is Moderna COVID-19 vaccine. Then it gives you the NCD-10 and NCD-11 number. What that is, that's a national drug code that uniquely identifies human drugs in the United States, and it also can be found on the vial containing the vaccine. And then there's an 11-digit number that's required on the claims to third-party payers, and those 11-digit numbers you need to find on those actual vials. And then there's another one. Let me just kind of go down the list here. There's one for Pfizer 91300. Says the same thing, vaccine administration code, and it tracks it and says first dose, manufacturer Pfizer. And then it says vaccine name Pfizer BioNTech COVID-19 vaccine. And then again, you get an 11-digit code that's required. And then it just keeps going down based on who the manufacturer is. So make sure that you take a look at that. They have them for AstraZeneca and for Moderna and for Pfizer Biotech. And it's really important because there's also another company that's almost on the rollout, and it's Johnson & Johnson. I actually may wait for that since I'm working so virtually nowadays and I'm not on the front line. And I also had COVID almost a year ago, and so still have antibodies. But the one thing with that is to make sure that you're have the right manufacturer. But Johnson & Johnson is coming out with just a single dosage, and so vial or vaccine, and I think I might wait for that. I'm not big on shots. And that, for me, it's just if I need to travel. I mean, if I'm going to be, think about what is going to be required and find out from your employer if they're going to require it. I know some will. I know that there's a big discussion about airlines right now, what they're going to require when it comes to the COVID-19 vaccines. Right now, if you travel internationally, they do require a negative test within the last 7 days. If it is domestically, many are requiring it within the last 30 days. I find it interesting for those of you that are still in the travel mode, where they have them now at airports where you can get a rapid test. But what if you already have your ticket? So you have your ticket, you're already going to go somewhere, and all of a sudden now you go ahead and do the test, and then it comes back positive. Not only have you exposed somebody in the airport from contact, but now you can't go. So I don't know if that's such a smart idea. But that's basically kind of what is going on in that realm. So make sure you do get that AMA tracker. That'll help you as well. So I want to talk to you, since we are now a day away when you hear this from a new administration coming into our government. Whether it's good or bad, it's going to change. So things are going to change. There's a lot of things out there that you need to be aware of. Number one is that and this is with any administration, so it doesn't matter who's going to come in the White House, but all of the proposed rules. So for example, there's a proposed HIPAA rule that would cut red tape and make, patient health information transfer easier. But all the proposed rules that were under the Trump administration will be probably halted for 60 days under the Biden administration, because that's what the new presidents do. They basically, or their new administrations do, I should say. They basically halt proposals and then determine if they want to move forward with them. Now, what about existing policies? Well, that they actually have to go back to Congress. Whatever CMS doesn't have the authority to change a lot of the telehealth issues. Now, because we're still under a public health emergency through April 21st, they will be in effect until that public health emergency ends. But again, once it ends, you can't just say executive order that we're going to roll back, one of the flexibilities to be permanent. It actually has to have a discussion, has to go to Congress, has to, basically be worked through and then possibly passed or not passed. So be aware, it's not just that these things will either stay or go. It's just certain things definitely have to go through the channels and the cycles. Now, then I'm just going to put this out here, and it may come out as a political opinion, because those of you that have been listening to my Codecast for 3 years, you know what my side is. But here's where we have a problem right now. We don't have a balance of power. So we have one political party that now controls the presidency, the House, and the Senate. So that, and then if there's a tie where you have anybody on either side of the aisle in the Senate or in the House, then the vice president gets to make that break, break that tie, which to me doesn't make sense, because obviously they're going to go with parties. So that's kind of silly. But it's going to be interesting, because one of the things that the reason we have several branches of the government is so that we have balance. And right now we're not going to have balance. So that is going to be pretty sticky, at least until 2022, when we see what happens there. So again, it doesn't matter what side of the pendulum you swing on when it comes to political. If there's no balance, it's going to be really hard to get the other side of the coin heard. So when everybody goes to one side. Couple of things just to make sure that you're clear. I've seen a lot of misinformation out there as far as the conversion factor and fee schedule. It is $34.89. Okay, $34.89 is our conversion factor. It got raised 7.4%. So actually the 3.75% was doubled on January 5th. So we don't know why that happened. And I'm still trying to figure out how that happened. The delay in the sequestration of the 2% that we've been getting taken out because of in the Obama days from 12/12, when they raised the debt ceiling, they had to take it out of somewhere, and of course Medicare got hit. Well, during the pandemic, that was extended through the end of last year. Well, that is extended through the end of March, and from what I'm hearing and from what the conversations I'm seeing from the political side, they can't extend it again. I guess the law won't allow. It allowed for 2 extensions unless the public health emergency is extended. And with the rollout of the vaccines, I'm not sure that will be extended. It just depends how well it is. Even though, yes, we are in a spike situation right now, it just depends on where we're at there. I'm hearing that now that the election is over and there's a change in the guard, that, of course, now the different cities and states are saying, well, let's open up. And I'm just like, okay, well, that's what we've been saying for 6 months, or that's what the current administration was. So anyway, we'll see what happens with that. If they open everything up, then you really can't still continue with the public health emergency. So we'll see what happens on that. Another thing that you want to really be mindful of is that there's a lot of health applications, health apps, or personal health applications that are out there right now. And basically there's a lot that are not FDA approved. And I'm talking about remote patient monitoring and certain things that I know a lot of vendors are out there saying, oh, this is something you can bill the remote patient monitoring codes for, and you can't. So make sure you know what's FDA approved. Make sure you go on their list, search it out, so that you're not trying to bill for something. Let's say somebody's got a blood pressure monitor on their iWatch. That's not something you can bill for. So it has to be an FDA approved device. Now, a couple of things that came out of the last final rule I think were missed, and I just want to make sure it's not missed when you look at reporting things and when you know what a qualified healthcare professional is or anything like that. This was actually well defined within the Act, and I just want to make sure you're aware of it. So the physician or other qualified healthcare professional, that is a physician or other qualified healthcare professional as an individual who is qualified by education, training, licensure, regulation when applicable, and facility privileging when applicable, who performs a professional service within his or her scope of practice and can independently report that professional service to the payer. So they're distinct from clinical staff. When you see clinical staff members, that's a person who works under the supervision of a physician or QHB who is allowed by law, regulation, or facility policy to perform or assist in the performance of a service, of a professional service. So make sure you know under the fee schedule who can report certain services, because sometimes I think clinical staff is a term that is used to describe staff members that may not be qualified, and they're not qualified to report directly. And you want to be clear, especially when you're reporting services such as chronic care management. So what does clinical staff mean, under that guise, if you will? Teaching physicians in primary care. So this actually was added to the telehealth list under the PHE. Just make sure you're really looking at this, because they're looking at some of the residents are reporting some of the higher levels of E&M services that may be outside of the scope of their approved GME program. So even though it may be something they're allowed to do under the telehealth, make sure that you're looking, if you're dealing with teaching physicians and residents, that their approved GME program, which are furnished to inpatients in the hospital, that what does their training program allow? Otherwise, that it may not be appropriate, especially as moonlighting residents, if they can do everything. And so we just have to really be careful of that, because outside a metropolitan statistical area, you have to meet certain criteria as a teaching facility or teaching physician. So it's really important for that. Also, keep in mind when we're talking about the remote services, the remote patient monitoring or remote physiological monitoring services, the new codes we have now, and the 99453 all the way up to 99458. Some of the things when we talk about these services, you've got to be a little bit cautious, because these services actually say an interactive communication, and that's a conversation that occurs in real time and includes synchronous, two-way interactive video and audio enhanced capability. But once the PHE ends, there must be an established patient-physician relationship for these services that are furnished only by physicians and NPP who are eligible to perform E&M services and can bill. So you may be finding that during the PHE certain things are reportable, but just remember that once the PHE ends, they're going to scale that back. Now, somebody asked about the certified nurse anesthetist when it comes to being able to supervise and administer diagnostic tests within the scope of practice, obviously in their state law, and as long as they maintain their statutory relationship under the Medicare with a collaborating or supervising physician. Yes, CRNAs were added to the list, but that's not an RN. That is a certified RN anesthetist. So make sure you're aware that NPs, certified nurse specialists, PAs, clinical nurse midwives, and then also CRNAs, that's an anesthetist. So just really be cautioned there, which also takes us to pharmacists. So providing services incident to physician services during the PHE only. The only thing a pharmacist could report, and again, under a physician, would be the nurse visit, and it's usually for the discussion about the testing and contact tracing and everything for COVID. I know that a lot of practices basically decided to get a pharmacist on board or use one within their kind of their ACO, and said, well, now they can bill for E&M services. I'm like, no. All they can bill for is something that's not covered under Medicare Part D, which still is statutory to what their licensure is. And their licensure is just about medications and talking about the scope of vaccines, talking about, testing. It's not about anything else that has medical decision making. So you have to be very clear about that and not go a little bit crazy. Sometimes we're seeing a lot of overcoding and incorrect reporting based on the provider, because everybody thinks that, now that we're during PHE, now that we have, ancillary staff allowed to participate in some of the documentation, then that means a free-for-all, and you don't do that. So that definitely is going to be an issue that's going to be looked at, and we just want to be very clear on that when it comes to understanding that definition. For those of you in the surgery specialty, I'm sure you've seen the outpatient prior authorization elimination of inpatient only list in 2021. Well, in 2020, CMS established a process through which hospitals must submit that prior authorization request. This applied to 5 categories. And basically now they're saying that in 2021, prior authorization is expanded to 2 additional services, cervical fusion with disc removal and spinal surgery, citing unnecessary utilization. So what CMS has done is they're eliminating the inpatient authorization, beginning with the removal of 300 musculoskeletal services. Find your list, you can Google it, but they're phasing it out over 3 years. And all procedures that were retired from the IPO list prior to 2021 will maintain a 2-year exemption rather than an indefinite period. But the reason I say this is because this I could see being rolled back by the new administration, only because the reason this was rolled back is that the Trump administration felt that the hospital costs were too high. That's why, he really wanted to bring down incorporate the transparency and all of that, where basically you have a level playing field. Same with, medications and drugs. Why are we paying more in the U.S. than they're paying in Canada or in Europe? Well, same thing when it comes to surgeries. Why are the patients subject to these really high costs when it comes to surgeries, when if it can be done in an ambulatory surgery center safely, then their cost goes way down. And a lot of people say, yeah, but if they're covered by insurance, what does it matter? It matters a lot. The high cost of healthcare also is contributory from what the payers are paying out, and they pass that expense along to you. For any of you that are insured and have insurance, that expense is passed along to you, because remember, insurance only works if you have healthy people. So any of you or us that are healthy, we're ended up paying for that as well. Well, the one thing that I can see this being rolled back on is that this definitely hurts hospitals. If hospitals lose a lot of business because they're too expensive and ASCs are popping up all over the place, then obviously there's going to be a bidding war for things, and they're going to have to come in line with what an ambulatory surgery center will do versus an inpatient hospital. And I could see possibly this administration, the new one, kind of erring on the side of the hospitals and saying, no, it's fine. We're going to go ahead and just, roll that back. So just keep an eye on that, because I've already heard and read some of the potential policies coming up, and it's more friendly towards the facilities than it is towards the patient. So be aware that things are coming. And I hope I don't sound angry today, but I'm just a little frustrated because there's been some great policies that have been over the last 4 years that have been installed. And I'm really going to be sad if some of them are rolled back, because these policies they've just been so patient friendly, and we need to keep that going. We need to be with patient friendly and making sure that, our healthcare systems aren't going to continue to be skyrocketed because of high cost. And so I'm hoping that definitely hopefully will continue to be, I guess, the subject matter moving forward. So hopefully it will be. We don't know, but we'll see, what the new administration is going to do. Okay, so next week I am going to get back to coding on the Codecast podcast. We're going to do some top 10 coding issues and some questions that have come in through my Coding Corner membership, which we've had a lot of people join in the last 3 months. So that's been great, having so many more members that want to get questions and coding responses. So we really appreciate having you. So anyway, just wanted to say, I hope everyone has a good weekend. I am a little bummed because my Steelers got kicked out last week from a really depressing game. And so now I'm watching playoff football with other teams, but what are you going to do? So onward and upward, and hopefully everybody is getting out in some of this weather. I know if you're on the East Coast, I'm still seeing that, well, I shouldn't say still, it's January. You're seeing snow. We're warming up here in California. Yesterday it was 78, and today looks like it's going to be in the 80s. So all kinds of different things going on there. So everyone, make it a great week, make it a great day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.